Hello, everybody. This is Dan from the Venting Wisely team, and over the next 20 minutes, I will talk about a novel method for performing an optimal PEEP study. But first, let's determine what optimal PEEP is. Optimal PEEP can be anywhere between the upper and lower inflection point on a pressure volume curve. So what is the goal of optimal PEEP? To identify a PEEP range that balances compliance, oxygenation, and driving pressures while minimizing ventilator-induced lung injury. We are saying it can be a range of values because there can be more than one optimal PEEP based on the patient's condition. Our team has created an algorithm that is quick, accurate, and easy to follow. The one caveat to this method is that it may be less accurate for the morbidly obese patient due to their body habitus. We recommend printing out an algorithm for yourself and use it to follow along during the presentation. We'll be breaking out each step of the algorithm and use actual PEEP table examples to help put it into practice. The algorithm is broken up into 4 parts: pre-procedure, safety check, procedure, and post-procedure. Step 1. Have a patient with a PF ratio of less than or equal to 200. Set your optimal PEEP study parameters to mimic your current ventilation settings. Target tidal volume 6 to 8 mL per kilo of predicted body weight, and adjust your FiO2 for saturation targets from 92 to 96%. This will allow you to spot changes more easily, as it's hard to say which PEEP is better if you are on 100% oxygen and your SATs don't change with differing PEEP levels. Once the vent parameters are set, perform a diagnostic recruit maneuver. This can be either a 30 centimeter water for 40-second breath hold or a 40 centimeter water for 40-second maneuver. Once your recruit maneuver is done, move on to the safety check. Set your PEEP to 24 or the predetermined level as per discussion with your physician or designate. Allow 3 to 5 breaths to be delivered and observe the plateau pressure and saturation. If your plateau pressure is less than or equal to 40 and your saturation is greater than 80%, you can move on to the procedure portion. However, if your plateau and SATs do not meet the advancement criteria, you would continue to decrease the PEEP by 2 centimeters of water and reevaluate the plateau and saturations until meeting the advancement criteria. The idea here is to limit the chance of causing any adverse events before moving on to the procedure itself. Once you pass the safety check, you can start the PEEP study by maintaining the PEEP level for 3 minutes and record the values in your PEEP table. This is where you will ask 3 questions about the results you record. Is the driving pressure less than or equal to 18? Is the plateau pressure less than or equal to 30? And has linearity been established? Now, what is linearity? We have defined linearity as a pressure drop in plateau pressure of less than or equal to 3 centimeters of water between PEEP levels. We will use this optimal PEEP study table as our example. Starting from the top of the algorithm, we have set our vent parameters, performed a recruit maneuver, and initiated the safety check. We set our PEEP to 24, allow 3 to 5 breaths to be delivered, then we check the plateau and the saturation. 38 for a plateau and saturation for a 94. Safety check passed. So we maintain the set PEEP of 24 centimeters of water for 3 minutes and check our values. Did we meet all 3 criteria? Driving pressure less than 18? Yes. Plateau pressure less than or equal to 30? No. Then follow the red arrows on the algorithm. Following the red no arrow, we come to another question. Is the exit criteria met? Is our PEEP equal to 8 centimeters of water? No. Is our saturation less than or equal to 80%? No. Then follow the red no to the next step of decreasing the PEEP by 2 centimeters of water and repeat. Set it and check it. Now we set our PEEP to 22, waiting our 3 minutes, then check it. Have we met all 3 criteria? No. Again, follow the red no arrow to the exit criteria. Is the exit criteria met? No. Rinse and repeat, or set it and check it until all 3 criteria are met. Set a PEEP of 20, wait your 3 minutes, then check it. All 3 criteria met? No, it is not. Continue moving down in PEEP. PEEP of 18, wait our 3 minutes, then check it. All 3 criteria met? Actually, yes. Our driving pressure, yes. Plateau pressure, yes. And what about linearity? Well, seeing a drop in plateau pressure of 2, then yes, we have established linearity from a PEEP of 20. And this is a good time to expand on that idea of linearity. Linearity is the point on a pressure-volume curve, which is between the upper and lower inflection points. Now, let's look at what those inflection points are. As you deliver a volume to a de-recruited lung, you will note that it takes more pressure to initially inflate the lung. Think of a balloon inflating. It takes much more pressure to deliver a volume into the balloon at the start. This can be identified by the lower inflection point. The pressure increases more than the volume being delivered. Simply, it could take 2 centimeters of water pressure to deliver 1 ml in volume. Then it becomes easier to deliver a volume into the balloon, and this is during the linear portion of the curve. And it could take 1 centimeter of water pressure to deliver 1 ml in volume. And finally, it becomes more difficult to continue delivering a volume into the balloon as it reaches its maximum size. And this is the upper inflection point. And again, it could take 2 centimeters of water pressure to deliver 1 ml in volume. Although the example used in the previous slides involves a pressure and a volume, this still translates when using a pressure versus a pressure curve, as we are using the comparison of PEEP and plateau pressure. The linear portion of the curve is clearly visible, and you can see how the upper inflection point increases in an exponential fashion. So we are defining what it means to be linear in terms of PEEP and plateau pressure. If you decrease your PEEP by 2 centimeters of water and your plateau pressure decreases by 2 centimeters of water, that is a linear exhalation, or a 1-to-1 ratio. Our team reviewed over 100 PEEP studies and identified that a 1 to 1.5 ratio shows that we are on the upper level of the linear curve and not above the upper inflection point. Simply, a decrease in PEEP by 2 centimeters of water and a plateau pressure decrease by 3 centimeters of water is also considered linear. Okay, back to our example. Previously, we were going from a PEEP of 20 to 18. There was a 2 centimeter water decrease in plateau pressure. We have established linearity, and we can also note that we likely would not include a PEEP of 20 as the plateau pressure is greater than 30 centimeters of water. Now that we have established linearity, we can follow the green arrow to the next decision point. Is the PEEP greater than or equal to 10 centimeters of water? This step was placed as we wanted to prevent teams from decreasing the PEEP to less than 8 centimeters of water, as we have identified 8 centimeters of water as the exit point to an optimal PEEP study. So back to the question, is the PEEP greater than or equal to 10? Yes. Then we follow the green arrow to the next step of dropping the PEEP by 2 to set it, and then check it to confirm linearity. So going down once more, we set our PEEP to 16, wait our 3 minutes, now check it. As we have already met the driving pressure and plateau pressure, our focus is on the plateau pressure decrease. Was the PEEP-PPLAT drop less than or equal to 3 centimeters of water from a PEEP of 18 to 16? Yes, there was a 2 centimeter water decrease, and we have now confirmed linearity from a PEEP level of 18 to 16. With linearity confirmed, we can now end the PEEP study at a PEEP of 16 and proceed to the post-procedure. This includes performing a diagnostic recruit maneuver, setting your identified optimal PEEP, and documenting it in the health record. Looking at the original PEEP study, we can see the therapist started at a PEEP of 24 and ended the study at a PEEP of 8. In the new method, we start at a PEEP of 24 but ended at a PEEP of 16. By ending the study and not decreasing the PEEP all the way to 6 or 8, we prevent causing added trauma and save spending another 12 to 16 minutes in a patient's room. There was one step we overlooked, and that's deciding what optimal PEEP we would have selected. If we had established and confirmed linearity for PEEPs of 20 to 16, we could likely pick a PEEP of 18 or 16 because they meet all the required criteria of driving pressure, plateau pressure, and linearity. However, we should also take a couple considerations into account. So let's look at oxygenation. If we visually compare oxygenation to PEEP, we can see that the best SATs occur at PEEPs of 20 to 18. The consideration is that your selected PEEP levels should be within 2% of the highest observed saturation value. And compliance. If we visually compare PEEP to compliance, we can see that the best compliance occurs at PEEPs of 18 to 16. The consideration is that your selected PEEP level should be within 10% of the highest observed compliance value, and this would include the PEEP ranges of 18 to 16. So the final choice is yours based on the patient's condition and your clinical judgment, but either a PEEP of 18 or 16 would be an acceptable choice. A PEEP of 20 could be considered as well in discussion with your physician or designate, as linearity was initially established at a PEEP of 20, but the plateau pressure was the only outlying factor. An esophageal balloon may be helpful in determining a transpulmonary plateau for this patient. Our team has created a reference for helping to narrow down the ideal optimal PEEP for your patient using the methods described in the earlier slides based on the considerations for compliance and saturations. So let's go through another PEEP table example. Using a printed algorithm to help guide you, let's break down this PEEP table. Starting from the top, we have set our vent parameters and performed the safety check. We set our PEEP to 24, waited the 3 minutes, and then check it. Driving pressure is good, but plateau is not. Continue down to set it and check it. PEEP of 22, same as before. Driving pressure good. Plateau not. Continue down, set it, and check it. PEEP of 20, same. Driving pressure good. Plateau not. Continue down to set it and check it. PEEP of 18, driving pressure good, and finally our plateau is less than or equal to 30. Now, what about linearity? Actually, there was nothing linear with the plateau being the same from PEEPs of 24 to 20, and note the driving pressures are increasing. This may be due to a morbidly obese patient. Just looking at these numbers and not the patient, we can only guess. For this example, we see the plateau pressure going from 31 to 27, and that gives us a plateau pressure delta of 4, so no linearity. Continue moving down to set it and check it. PEEP of 16, driving pressure good, plateau good, linearity. Well, with the plateau dropping from 27 to 24, this gives us a delta of 3. So we have established linearity. So let's go to the next step in the algorithm. Now that we have established linearity, we come to the next question. Is the PEEP greater than or equal to 10? Yes, it is. So then we can proceed down to the final step of confirming linearity, of set it and check it. Now, PEEP of 14, driving pressure good, plateau good, linearity, plateau delta of 2. Finally, we have confirmed linearity, and you can now end the PEEP study. So we have identified a PEEP range of 18 to 14 that meets all the criteria. Now, using the two considerations, what PEEP would you select? Where is the best compliance? A PEEP of 16, and a 10% range gives us a PEEP range of 18 to 14. And where was the best saturations? Well, both PEEPs of 18 and 16, and a 2% range gives us a little further of PEEPs of 18 to 14 as well. So the answer, any one of these three based on your clinical assessment and potential discussion with your physician or designate. I would choose a PEEP of 16 as it ticks all the boxes and gives us some room with that plateau pressure. Now let's go over one more. So from the beginning, we would do our pre-procedure and safety checks. Once we have passed those, we can start the procedure. And where have we met all three criteria of driving pressure, plateau pressure, and linearity? Driving pressure has been met at PEEPs of 24 and below. Plateau pressure has been met at PEEPs of 20 and below. And what about linearity? Well, we've been able to establish linearity at a PEEP of 24 and confirm it at a PEEP of 22. However, we were unable to have that plateau pressure within range until a PEEP of 20. So going one more time to allow yourself some wiggle room when performing this study is acceptable. That means you could have ended the PEEP study at 20, as you are well within the linear portion of the curve, but leaving that best plateau at 30 could be uncomfortable. Now the analysis and considerations. Best compliance at PEEP of 18 and a 10% variance gives us a PEEP range of 22 to 18. And our best SATs occur from PEEPs of 20 to 18. So my answer, I would choose a PEEP of 18, again for that plateau pressure wiggle room and marginally improved compliance. Now that you have the hang of it, let's look at two more examples. However, this time I will show a PEEP table and you will get to figure out what optimal PEEP is based on the new method. In order to do this, you will have to pause the video so you can analyze the table and then restart the video and I will give you a breakdown. Here is the table. This is an original PEEP table as recorded by one of our therapists. Note that they started at a PEEP of 24 and ended at a PEEP of 8. Go ahead and pause the video. Use a printed algorithm to identify what optimal PEEP you would select and restart when you're ready to move on. Welcome back. For this table, I would have started at a PEEP of 22, ended at a PEEP of 12, and have selected an optimal PEEP of 16. This table is a great example of how linearity can change throughout a PEEP study. From the top, the PEEP of 24 would have been eliminated as the plateau was greater than 40 within the safety check. So we would start the procedure phase at a PEEP of 22. Also of note, our driving pressure is within range from a PEEP of 22. So what we are going to focus on is the plateau pressure and linearity. So let's continue with the set it and check it. PEEP of 22 does not meet the plateau range. Continue down. PEEP of 20 also does not meet plateau pressures. Continue down. PEEP of 18 finally meets the plateau pressure criteria, and the drop from a PEEP of 20 to 18 plateau delta is 3. We have established linearity. And as the PEEP is greater than or equal to 10, we can continue down to try and confirm linearity. So PEEPs of 18 to 16, our plateau delta is now 4, no longer linear. So now we would follow the red no to the exit criteria. Have we met the exit criteria? No. So let's continue down to set it and check it. PEEP of 16 to 14, our plateau delta is now 1. We have reestablished linearity. And PEEPs of 14 to 12, our plateau delta is 2. We have now confirmed linearity. And we can end our PEEP study at a PEEP of 12. Next, let's take the compliance and saturations into consideration when selecting the best PEEP. That still gives us a PEEP range of 16 to 12. Ultimately, the choice is yours, as seeing the patient provides you the full picture. Again, I would choose a PEEP of 16 with the lowest driving pressure and acceptable ranges for saturations and compliance. Okay, here's one more. Pause the video, then restart for the answer. Welcome back. For this last table, I would have started at a PEEP of 20, as the PEEPs of 24 and 22 would have been eliminated in the safety check phase. And I would have ended the study at a PEEP of 12 and chosen an optimal PEEP of 14. We can see linearity is initially established at PEEPs of 20 to 18, and then lost going from 18 to 16, reestablished from 16 to 14, and finally confirmed at 14 to 12. Taking the compliance and saturation into consideration, our best SATs within 2% and best compliance within 10%. That gives us a PEEP range of 16 to 12. Based on the numbers here, any PEEP within that range could be considered optimal. I would have chosen a PEEP of 14 as it has the highest saturation and a compliance that is within 10%. That concludes our presentation on a novel approach to determining optimal PEEP. Please contact Dr. Ken Parhar, myself, Dan Jewers, or Pete Dillon with any concerns or questions. Thank you.